Hello, I'm Dr. Priya Singh. I'm reader in the Department of Oral Medicine and Radiology, BBT COTS, BBD University. The lecture that I'll be discussing today is Artifacts in Intraoral Radiography. So first of all, it's important to know what is an artifact. Artifact, it is basically an additional, missing or distorted image which does not conform to the real image of the part being examined. Now, many a times these artifacts, they overlie on the pathology or they may overlie on the normal anatomical region, thus creating a nuisance, thus creating an impression of a normal anatomical landmark being a pathology or maybe a pathology being a normal anatomical landmark. So it's very important to know about artifacts. Now, recognition of artifact is important because they can be misleading and they may even be mistaken for some important finding that may affect the diagnosis. In intraoral radiographic errors, there are basically three groups of artifact. First being the technique error. During the technique, if something has gone wrong, under this category, there will be various artifacts which I'll be enumerating. Second being the processing artifact. Even if the technique has been done very nicely, but if the processing has not been done adequately, again few artifacts or errors can be seen. And the third being the manhandling. At times, all these technique as well as processing, even if done very nicely, but the preservation has not been done nicely, again can lead to artifact. So first of all, the classification of artifacts into these three broader categories and identification of each will help in relieving or not making these errors in future. So patient preparation errors, first of all, is radio opaque artifacts. Now, if during the patient preparation error is done, then it can be due to the presence of dental appliances, jewelry, eyeglasses, etc., which might superimpose over dental images. Thus, it's usually said that the preparation of the patient before taking the radiograph is very important. Once the radiograph is advised in the patient and the patient is made to sit on the dental chair where you'll be taking the radiograph, first of all kind of appliances in the patient's oral cavity which might cast an impression in the final radiograph should be removed. The jewelry which the individual is wearing should be removed. Eyeglasses, at times for the maxillary anterior region, for the upper teeth, if there is any eyeglasses rim overlying over that particular region, that can also superimpose in the radiograph. So very important that patient preparation should be done adequately. Second very important aspect is you have to orient the patient what you are going to do. You have to orient the patient that during the whole procedure, there should be no attempted or any movement in the patient. Patient has to hold the film very firmly inside the oral cavity, though we have different holders, but at times holder might lead to gagging. It might impinge on the soft tissue. So we make the patient hold the film, but you'll have to convey the patient that the movement of the film should not be there. Even the patient should not move throughout the procedure, even if it's for milliseconds. The X-ray source has to be kept stabilized, and this has to be done by the technician who's taking the radiograph. So even the source should be very stable. Otherwise, all these three things, that is the movement of image receptor, patient or X-ray source, they might result in a blurred image. We have to explain thus the patient the whole procedure, the time taken, and if in case anything goes wrong, the second attempt has to be done. And since most of the patient now know the hazards of X-ray, they will be cautious while the radiographic procedure is being done. Then the film placement error, at times the apices is cut off. If we have not placed the film correctly in the oral cavity, depending upon which region has to be identified or radiographed, the apices, the periapical region, which is usually of the most interest, because clinically you have already seen the coronal aspect. It's only the root region or the periapical region which needs to be seen to confirm with the diagnosis. So it usually occurs when film is not positioned apically enough to record entire tooth. It can correct this in paralleling technique by moving film further away palatally from teeth in maxillary arch and more apically in the mandibular arch. So it's usually said that at least 1/8 of the film should be seen above or below apices of the teeth. Insufficient angulation at times can also project apices of teeth off the film. So very important that the film placement, depending upon whether it's for the anterior region, that is the front region, or posterior back region, the placement has been done adequately. At times, the specific region might not be covered. It might be because of the result of not placing film to cover all teeth in the area of interest. So there are three major guidelines to minimize positioning error. First of all, the distal surface of canine visible in premolar views. Third molar or retromolar tuberosity areas in molar view, and two teeth of interest to be centered on film. Now, the area of interest or the tooth of interest should always be in center. Only one exception being the third molar, because obviously you cannot place the film so posteriorly. Otherwise, in rest of the cases, you should always try that the area of interest should be in the center. Backward film placement. When you are taking radiograph, maybe for the first or the second time, this might just happen. So you should be knowing that what is the right side or which is the tube side of the film or the image receptor. When we talk about intraoral radiographic film, it's usually the flat side or the white side, which is the tube head side, whereas the envelope side or the flap side is the back side. So likewise, you have to place the film in the oral cavity of the patient. Otherwise, a low density herringbone or tire track or geometric pattern will appear in the final radiographic image. As you can see in both these radiographs, you can see tire track appearance. So this tire track appearance can be exempted. You can be relieved of it if the film placement has been done properly. Whereas if you reverse the film in the oral cavity, it will lead to this kind of appearance. So beforehand only you should be knowing that which is the tube side of the IOPA film. Next is the dot artifact. In all the intraoral radiographic film, you will see that there is an elevation at one end. So that dot is nothing but occlusal dot. It has been given the name of occlusal dot because if you are taking a maxillary radiograph, it has to be placed downwards. And if you are taking for mandibular, it has to be placed upwards so that identification of the tooth becomes easy. So this identification dot, it produces a circular radiolucent artifact on final radiograph. At times, it might interfere with the apical area of teeth. If you don't know that this particular dot where it has to be placed, at times at the periapical region, it might lead to feeling of a pathology or maybe a anatomical landmark being superimposed in the region. So it should be placed adequately. Next being the double image. When an exposed film is placed in another region and re-exposed, resulting film with two superimposed images, as you can see here, it almost looks like a snail. So identification that it has been exposed twice is very important. Even in the second radiograph, you can see that there is vertical as well as horizontal image of the dentition. So this is because exposed radiograph has again been exposed, double image being procured. Next being tongue or finger artifact. At times, while holding the film, as I have just conveyed, that film holders are the ones which are utilized. But at times, if it impinges on the soft tissue of the patient, we make the patient hold it with a finger. But if the finger comes in between the X-ray source and the image receptor, then it causes an impression of the finger, which is also called as phalangioma. Identification of this is very important, otherwise it leads to the impression of a pathology at that particular site. Then overlapping error. Overlapping is usually caused by improper film placement. So if you can see here in the bite wing image, there is improper proximal areas where you can feel as if crowding of teeth is there and one tooth is overlying over the other. But this is because of the improper film placement, and at times it is even because of improper horizontal angulation. So overlapping error should also be checked. Next is film placement error or overlapping. Flat plane of film should be positioned parallel to mean tangent of teeth to be radiographed. Otherwise, the contacts and embrasure between teeth will be overlapped. And it seems as if crowding is there in the patient. But you can check it clinically also with the patient, and you will see that clinically there is no crowding. So this is basically because of the film placement error, which can be avoided if you know that why this overlapping is seen. Horizontal angulation error, as I've just told you, this is the other way by which overlapping can be seen. This basically happens because our dentition, it follows a curve of Spee. If we have not followed the curve of Spee while exposing the area, while directing the X-ray to it, then it leads to horizontal angulation. Just for example, we know that molars, it follows this angulation. If we direct the X-rays from front to back, the front teeth will seem to be overlying on the back teeth. And same thing can happen if we have placed the X-ray tube head from backwards to front. Again, the back tooth will seem to be overlying on the front tooth. So the angulation and the horizontal angulation as well as vertical angulation should be taken care while taking a radiograph. Shape distortion error, this is also very important aspect, especially when we are following a certain pathology. If we want to see whether the pathology has progressed or regressed in size and shape distortion identification becomes very important. So shape distortion error, it is caused by improper vertical angulation or placement of film. Foreshortening, foreshortening is usually seen when too much of vertical angulation is used. So you can memorize it like if you have given too much of vertical angulation, the image, the final image that will be procured, you will see it as shortened. So it's just the inverse situation that happens. And same thing happens in elongation. If not enough vertical angulation is used, then elongation will be seen. So identification becomes very easy, and you know that where which angulation has gone haywire. Film distortion, if patient exerts too much of biting pressure on bite block or film backing portion of bite block is trimmed or removed. So again, you have to convey the patient that patient should not bite on the film, otherwise it will lead to distortion of the final image that will be procured. Dimensional distortion, this dimensional distortion is inherent in bisecting angle technique, which we can eradicate when we are doing the intraoral radiography by paralleling technique. That is why it is said to be a standard technique, but being an easier technique where it can be advised in almost all the patient, bisecting is what is usually followed. So you should be knowing priorly that how to minimize this dimensional distortion in bisecting angle technique. It is seen as length distortion of root of maxillary molars, elongation of palatal root, and foreshortening of two buccal roots, as you can see in this particular image. So uneven magnification, elongation, or shortening can be indication of dimensional distortion while taking a radiograph. So correction of this can be done by either doing the bisecting angle technique very properly or by doing it with paralleling technique. Then is cone cutting error. This usually happens when you have not assembled three very important aspects, that is the X-ray source, that is your tube head, with the image receptor and tooth of interest. If they are not aligned, then it will lead to partial coverage of the film, or the X-rays will not be directed, as you can see here. That is why this cone cut, since the X-ray tube is in a cone shape, here this white region is the region where X-ray has not reached. So the placement of the X-ray tube head should be in same line as the image receptor and your tooth or area of interest. Very important, otherwise it will lead to partial image formation. Crown of teeth not showing, though most of the time when we are taking an intraoral radiographic image, it's usually the root region and periapical region which we have not seen clinically, which we are more emphasizing on. But for incipient carious lesion, but for pathology where the coronal aspect is not identified, maybe a proximal carious lesion, incipient in origin, or even if deep, involving the coronal aspect, the crown has to be seen in totality. So crowns of teeth, if not showing, it is because of film not being placed properly, not being extended till the coronal region. So whenever you're placing the film, should always see that it should cover the coronal as well as the root region. Otherwise, one or the other aspect will be compromised. Then coming to the second category, that is the exposure and processing errors. As I have told you earlier also, if the technique has been done properly, but if the exposure or processing errors are there, it will lead to major artifacts. And at times you won't be even able to do interpretation of such radiographs. So first, most important and more frequently seen is the blank film or no image. It occurs in several ways. X-ray not turned on or control panel set for another tube head. So this usually happens when you are taking radiograph in the first week. Failure to align indicating device with film. As I've just told you, X-ray will not cast on the film itself. So the film will be completely blank or white. Timer button may not be depressed properly, so the exposure will not take place. Film was not exposed at all. So all these will lead to blank image or completely no image being formed. Low density film image, it may be result of insufficient radiation exposure or a processing error. Exposure factors must be checked beforehand. A common error is not aligning your indicating device properly. So as I have told you, very important to align three things when you are taking a radiograph. And once you have made the patient sit, should always check it again before doing the exposure. May also result from a drop in line voltage or insufficient power at time of exposure. Now this is beyond our reach, and if it has happened, you should be able to identify the artifact and even convey the patient that this was beyond your control. Then processing factors, at times the solution itself is not adequate or it is with some depletion. So that should also be checked before actually processing a radiograph. The developer solution might be low in concentration. The temperature of the solution might be low. Insufficient developing time might be given while processing. Exhausted or contaminated developer might be there. Over fixation can also lead to processing errors. So after 2 or 4 weeks, solution need replacement. It's usually said whenever processor is used, whenever replenishment is done, a date should be mentioned over there, so that depending upon the uses, depending upon how many radiographs are taken in a day, it should be checked whether the processing solution has to be replenished after 2 weeks or 4 weeks. Otherwise, the radiograph will require a second exposure. High density or dark image. It may be result of too high radiation exposure, overdevelopment of film, or unsafe darkroom. So again, beforehand only all these areas should be checked so that artifact should not be seen. Exposure factors must be checked for exposure setting. Film speed should also be checked. Now processing factors might be leading to high development solution temperature, prolonged development time, and over strength of developing solution. So all these aspects should be checked beforehand. Depending upon which season the radiograph is taken, again, as I told you, if the solution has been prepared afresh, then you know that it requires less time for developing, it requires less time for processing as compared to a solution which is depleted. So knowledge about the temperature of the solution and concentration of the solution is very important. Otherwise, it will lead to a light or a dark image. And again, you won't be able to do interpretation of either of the two. Partial image. A technically accurate and properly exposed film with partial image can be of no use. It happens usually when the processing solution has gone too down in the tank. It happens when the solution is not up to the mark. So as I told you, it should always be replenished depending upon the daily, weekly, or the monthly uses in that particular darkroom. Black artifacts, contamination of film surface before immersion into developer, it can result in artifacts. So even that should be taken care of, that before opening the film, your fingers, your hands should be completely clean, and the holder with which you are going to hold your IOPA film, that should also be without any solution. Otherwise, beforehand only, it will lead to contamination and it will lead to black artifacts. Contamination might include developer chemical before actually putting it in the processing solution, moisture, light leaks, and overlapping of film during processing. So all these will lead to black artifacts. Careful handling of film by edges will prevent fingerprint. Now, many a times it's seen that the technique has been done properly, the exposure is done properly, even the processing has been done, but during processing, the fingernails will lead to scratch, will lead to finger marks over that particular region. So avoid holding the film from the surface, should always hold the IOPA film from its edges. Very important. Otherwise, it will lead to a major artifact. Black streak, as you can see in this particular image, it results from over inspection of film during development. Lack of proper film agitation when first immersed in processing solution. So at times what happened that when you have put it in a processing solution, you are supposed to keep it moving rather than letting it be there. So otherwise, it will lead to such stir or accumulation of solution at particular region. Fixer contaminated processed hanger clips, which I have told you earlier also, that the hanger clips should be completely clean before a new IOPA film packet is opened and your image receptor is placed in that particular holder. Insufficient fixing or improper rinsing can also lead to black streaks. Then coming to white artifacts, pre-contamination of film surface with fixer and air bubbles can lead to white artifacts. It's just the reverse of dark artifacts. So there the pre-contamination was with developer. Here the pre-contamination of the film secondary to a developing solution, there it was because of the fixer. It can cause teardrop artifact. As you can see here, teardrop artifact. So it might lead to the impression that there is a supernumerary teeth over in the alveolar bone. But identification of this will also be easy if you know why this artifact is seen. Fixer solution of finger can cause fingerprint, as I just told you. It can be contaminated with your fixer solution. So you can avoid this. Deposits on film. Chemical precipitation due to contaminated, improperly prepared or exhausted solution adhere to film surface. So all these deposition on the film can also lead to unclean surface, as you can see in this particular radiograph. And if it lies on the pathology, if it lies on the normal anatomical region, it will be difficult for you to do interpretation. Unclean film hanger clips may also carry chemical deposits. So after every day's exposure or if every day darkroom procedure, all the hanger clips should be cleaned. And you should be sure of that it should be dry before actually clipping our IOPA film. Stains. As you can see here, it's brown color stains. Same as happened here, brown color stain. It mostly result because of exhausted solution or insufficient rinsing. So processing You should be very sure of how it has to be done, when the IOPA film has to be rinsed and when it has to be washed. Because we don't want that everything has been done properly, but because of insufficient rinsing, because of insufficient washing, it leads to brown stain, maybe after a day or maybe after a week or a month. So brown stain can also lead to artifact, which at times might take time also to show on the final image. So once the processing has been done, the IOPA film should be washed properly. Now coming to automatic film processing errors. So these were the manual processing errors, which is usually done by the individual, but at times it can happen even in the automatic film processor. First condition that can happen is low density film, where the solution is too low, exhausted developer, which needs replenishment with time, improper agitation, as I told you, you have to stir it, and processing too fast. Now, high density film, just the opposite of low density film, the causes solution when overheated, light leaks, too much of replenishment. So it should be adequate. Neither it should be depleted beyond, neither it should be replenished beyond. Wet tacky film, developing temperature and dryer temperature when it's too low. Dryer thermostat control heater inoperative, or drier air circulation is inadequate. So all these can lead to errors in your final image. Film discoloration, which is the brown image, which can be seen even in the manual contamination. This is by fixer, by developer, if it has not been washed off and some remnant is there. Film discoloration in the form of greenish yellow can also be seen. Fixer solution being exhausted. Wrong film type for processing solution. Fogged film can be seen in cases of incorrect safe light, light leaks, high developer temperature, and improper storage of film. Streaking, as streaking of hair is seen, it can be seen because of under replenishment. Rollers with chemical deposits, dirty water wash, and film which is not hardened properly. Not hardened properly means not fixed properly, because fixation, it makes the image permanent. If the fixation has not been done properly, with time this streaking can develop in the image. Surface marks, foreign material irregularities on rollers, rough handling of film before processing, all these can lead to surface marks. Jams, failures of film to transport. At times it can be because of the error in the machine itself. Chemical being contaminated, chemical temperature too high, dirty rollers, rats not sealed properly, bent film corners as leading edge. So you should be sure about that. In the automatic processor also everything is clean, and the rollers through which it's going to move from developer to rinsing to fixing and final washing, it should not be contaminated with any solution, and it should be functional. The movement from one tank to other tank should be smooth. Now coming to the third and the final error, which is the film handling error. Even if the technique has been done properly, the processing has been done properly, but you, after processing, you are not handling the radiograph adequately, it can lead to errors. Again, you won't be able to interpret the radiograph. So first being the pressure marks, writing on film packet with ballpoint pen. Very frequently students do that. After taking a radiograph, they place the film inside and they then want to write which radiograph it is. With sharp ballpoint pen, if you write over it, it will lead to marks like this. So you have to be very careful while marking which region radiograph it is. Bend marks. Black linear artifacts are result of bending of film. So bending of film should also be avoided. At times bending is done when we want to take image of the posteriors, and so that the patient should be comforted, we bend the film, but the bend should not be very sharp. The bend should only move the film rather than bending it into an edge. Black crescent creases are result of incidental crimping of film, as you can see in this particular image. All these are sharp bends which are which might be at times not only by the technician, even when the patient bites on the image. Moisture contamination. Now, at times, everything is done properly, but you have not preserved the image properly. You have not dried the image before placing it in the packet. Saliva contamination of film packet causes inner black paper wrapping to become soggy. Film emulsion produces a black artifact. As you can see here, you can see a black artifact. Moisture on finger can also produce artifact. So I've conveyed you earlier also, our fingers, our hands, the holder with which we are holding, everything should be dry and clean. Static electricity. A dry indoor environment and rough unwrapping of film or rapid sliding of film may produce a small charge of static electricity. As you can see in this particular image, this static electricity can lead to black color of electric light impression. Also, synthetic uniform material and rubber sole shoes against carpet. So static electricity can be produced, which can be avoided while the final image is being procured. Torn, emulsion and scratches. It's usually said in the dark room that you should not be having very long fingernails. Careless handling of films during processing result in removal of emulsion and a visible scratch when film surface is examined in reflected light. Dust and powder artifacts. Film in contact with dust, grit, dirt or glove powder before processing can result in pinpoint black artifacts on film emulsion. So even that should be avoided. Film fog, which again can be because of n number of reasons, can lead to image being completely distorted. So which is evident by a dull gray low contrast image, final image being procured. Films can be fogged by use of outdated film, improper film storage, improper safe light condition, high developing solution, temperature, white light leaks, and scattered radiation. Chemical film fog may be due to excessive developing of solution, temperature, contaminated or exhausted developer solution. So I want to say at the end of the lecture that artifacts can be avoided if you know all the artifacts, their causes. So never remove a radiograph which has some artifact, because remember, each and every mistake we should learn from it rather than trying to forget it, because otherwise if you'll try to forget it, you'll make the artifact again and you'll make the patient being exposed again. So keep the artifacts also with you so that next time you remember that if you do some malhandling, if you do this particular thing improper, it can lead to artifact, maybe during the technique, maybe during the processing. And even if everything has been done properly, if you have not dried that radiograph before placing in the envelope, even then, and maybe beyond the time it's in the envelope. So important that you should preserve these radiographs even so that patient should not be exposed more than once while investigating a particular pathology. Thank you.